Welcome to The Kick, your expert-led podcast helping you explore and learn everything about getting pregnant, pregnancy, birth, and becoming a parent.
On the podcast and our online pregnancy program, Grow My Baby, we share my experience of helping more than 4,000 babies to be born.
And our experience of running a women's health clinic and parenting 4 boys.
We're here to help everyone to feel empowered in pregnancy and birth with real-life practical information.
Welcome everyone, I'm Brigid Maloney.
And I'm obstetrician Dr. Patrick Maloney.
And today, look, we haven't had a fresh episode in the can for all those people in podcast land. I don't know what I'm talking about for a little while because you've been concentrating on something else, Pat, haven't you?
I have. I've been doing my training and initial cases, learning how to use the Da Vinci robotic system for gynecological surgery, which has been absolutely fascinating.
It's so funny. So when I told my mum, and, you know, she is 83 with dementia, so take that all into account. When I said, oh, Pat's learning how to do surgery on a robot, she got that.
What was wrong with that poor robot?
That's exactly what she thought. She thought you were actually operating on a robot. She's like,
excellent.
Whatever forbid.
I'm happy for her to continue to believe that.
Yeah, but maybe because it's going to become more common, people are going to start knowing people that have had surgery on a robot by a robot platform before.
Yeah, I think that's right. So right now it's still kind of reasonably new, certainly in benign gynecology. The gynecological oncologists, the cancer gynae surgeons have been into it for quite a while, and it's probably getting a bit more common for, benign gynecological problems like endometriosis or uterine fibroids as a way of doing a hysterectomy, taking out ovaries, taking out endo. And it's been limited somewhat by cost. The robot itself is very expensive.
Oh, like millions of dollars.
Yeah,
isn't it?
That's right. Yeah. But it has some very exciting benefits. It's a joy to use. The vision you get is unbelievable. The post-operative results are extremely good in terms of length of stay, patient post-operative pain, quality of recovery, and so forth. But from my point of view, it's just a delight to use. The vision you get on the console is unbelievable. So it's a bit of a learning curve. I've done thousands of cases of traditional laparoscopy approach to things where you're actually standing at the bedside holding onto the laparoscopic instruments yourself, and the robotic platform, of course, is where a robot comes over the top of the operating table once you're asleep. The instruments are attached to the robot, and then the surgeon sits at a console and controls the robot.
Yeah, kind of quite separate to the patient, isn't it?
Yeah, you're over in the corner of the room, and that takes a little getting used to.
Yeah.
Yeah. Just yesterday I was asking a vaginal assistant to move an instrument, I said, towards me. And that's a traditional laparoscopy sort of instruction, which would mean towards the patient's head. But I was not standing towards the patient's head. I was sitting in the corner of the room. So I didn't mean towards me. I meant towards where I would otherwise be standing if we weren't using a robot. Yeah.
God, all these years, Pat, and I've never thought about that. So you're actually, I always thought that you'd be standing towards the legs of the patient.
You stand up near the head.
Wowzers.
Yeah.
I did not know that. God, and so did the assistant then go, hang on a minute.
Yeah, I think I know what you mean. Yeah. So that's what I've been up to, and it's been terrific. It's going to become really important part of my practice, I'm sure.
Yeah.
I'm now one of a very, very few gynecologists practicing in regional Australia who have the access and now the full training in robotic gynecology. So it's a very exciting time.
I know one of the very first patients that you did surgery on, and you came home and you said to me, oh, well, she was just sitting up in bed. Like a couple of hours later, she was eating. And she said, Dr. Pat, no shoulder tip pain? Yes,
yeah. It has a number of benefits like that, which you really have to see to believe.
Yeah.
It's been amazing.
And so Pat has been having enormous hours. So
the training
50, 60, 70 hours a week.
The training on the simulator, really the robot's in use during the day. So to use the simulator, which attaches to the real platform, you have to access it after hours. So I've been in there in the hospital at night time practicing on simulations and then moving on to a series of what they call proctored or supervised operations. And then now I'm all done.
Good. Well, good. We're here making a fresh new episode for everybody.
Good.
And we thought, the speak pipes have been banking up again. We love all your questions. There's so many. I've picked probably 6.
Well done. It's good to hear people's voices.
It is good to hear people's voices. So I think we should just get stuck straight into that. And we're going to start with this one.
Hi, Dr. Pat and Brigid. My name's Laura and I'm currently 12 weeks pregnant. I've started listening to your podcast and I haven't been able to stop. I just wanted some advice around if I would be a potential candidate for a VBAC. I tested positive for Strep B in my first pregnancy. Because of that, they told me I needed to be induced. So my waters broke at term. I went into the hospital. They induced me with Pitocin. I had the IV. However, I wasn't able to progress further than 2 centimeters, hence needing a emergency C-section. I'm just wondering this time around if I test positive again to Strep B, will I still need the induction and will I still be able to potentially progress this time around? Any advice would be appreciated. Thanks.
Now, this is my second listening to this. And the first time I listened to it, I went, hang on a minute, Strep B, induction. I get it now, though. I know what you're going to say.
So I think this would be better described as augmentation. So it's a technical thing, but we tend to describe induction as being when someone is not in labour, nothing's happening, and we think that baby's better off out than in. Let's try and get that labour up and going. And ideally, that's for good reasons. And augmentation is typically the term we use when somebody is in labour and we want it to go faster. So when we talk about someone with Group B streptococcus, remember it's not an infection. That Group B streptococcus, GBS, belongs in the vagina. It's present in the vagina of 20% of women at any given time. But if a baby comes out after a birth with an infection, serious things, meningitis, encephalitis, septicemia, the culprit is often GBS from the maternal vagina. And the outcomes can be very serious. Those babies can become sick very quickly because once that bacteria gets away from where it belongs in the vagina into a baby's bloodstream, it's very damaging. So they started a process in the very early days of my training to swab for it, and then if it was there, push the labour on a bit faster, and then give antibiotics in labour as well. And since it's been done that way, there's been better results, much, much better results. A bit like vaccination, we treat a whole lot of people to save a few. But the rates of babies with a thing called early onset GBS sepsis, so straight away come out heavily infected with GBS, has come right down since it's been done that way, and it's generally considered an intervention in the birth process that's worth it. But some women need to have some syntocinon augmentation in labour, which they otherwise would not have had, and occasionally that will lead to caesarean section.
Particularly because her waters broke first. So
when the waters break, that's when the baby's exposed to the GBS in the vagina, and we want that period to be pretty brief. Now, what happens, of course, in a natural labour first baby at term, the waters break, it can take ages for the contractions to come. So if someone's got GBS positive, on a swab taken at 36 weeks, that predicts that the GBS will still be there a month later when the waters break. and that woman is best off getting on with it.
Mm.
So we'll use a bit of syntocinon to get the show on the road, to get the contractions coming. But occasionally an induced or augmented labour will end in caesarean section. Sometimes it's hard to tell whether that was going to happen anyway or whether the use of syntocinon has actually increased that woman's caesarean section risk. And this is typical example of obstetrics where we're trying to play off one risk against another.
And she wants to know, like, whether in a subsequent birth, whether she would go ahead and have a VBAC or whether she should, and have a planned section. And that's the $1 million question, which has been asked over and over and over in our speak pipes lately.
How do I determine if I'm a good candidate? Yeah. So look, it's a tricky one. There's nothing about this story that I think makes this person a bad candidate for VBAC. We worry about a different scenario. Well, I'll give you a different scenario. A very small, petite woman with a 7-foot husband.
He's growing in feet every time you say this story.
has a 4.5 kilogram baby and obstructs at 4 centimetres and has a caesarean section. If she rocks up for a VBAC, the same thing is quite likely to happen again. And she might be considered a poor candidate who might be better off with a planned section. But in this situation, obstructing at 2 centimetres or developing an abnormal fetal heart rate at 2 centimetres and needing an emergency caesarean section delivery, most people would consider that that's an unknown candidate and really could give VBAC a try. One of the things that would be nice would be if the GBS swab at 36 weeks in the subsequent pregnancy was negative. Yeah. Which, of course, it might be. It comes and goes. So that you were less there was less need for augmentation. Yeah.
And, yes, augmentation, not exactly induction. So her ball started rolling once her waters broke. And
yes, that's when it suddenly –
yeah, that's where Strep B became the issue.
Yes.
But if she went along and just knew that she had Strep B, but then went into labour naturally for a VBAC.
And laboured quickly.
Yeah. She wouldn't need any augmentation.
No, that's right. So best case scenario would be to test negative.
Yeah.
Second best case scenario would be to test positive at 36 weeks but labour efficiently at term.
Yeah.
Which, of course, might happen second time around.
Yeah.
So the waters break, the contractions come quickly, nobody comes near you with any synto, and you have essentially a normal, non-augmented VBAC labour.
Yeah. Now, Lauren, we've done lots of episodes that I think might help you here. We've actually done a Strep B episode. We've done a VBAC episode and an induction episode. So maybe have a listen to all three of those. This is where, if you're in our program, you would naturally be presented with that information. So, you're going along in your pregnancy, you haven't even thought about what a Strep B positive test might mean for you. Then in the Grow My Baby program, you're presented with that information. So you sort of know that information before you're sitting in your doctor's office or your midwife's office and all of a sudden you're presented with the information. You go, hey, hang on a minute.
These are the questions I need to ask.
Yeah. Good. And good luck. Good luck with all your choices there.
A strapless bra that stays put or wire-free support that actually supports. That is Nala. They do the inclusive sizing A to J, wire-free support and straps that stay put past 3 p.m. Right now, Mamamia subscribers have 25% off site-wide. We call it the subscription that pays for itself because realistically, one Nala shop, and I do shop at Nala very often, it covers the cost of your membership for months. If you are already a subscriber, the code is in your subscriber hub. And if not, join via the link in the show notes and you can unlock it instantly. Support women's media while Nala supports you.
Let's move on to our next caller.
Hi, my name's Rebecca. I would love some advice on breech babies. I have a very stubborn breech baby that is refusing to turn. Can you talk through some of the pros and cons of ACV and particularly weighed against the risks and benefits of going straight to a Caesar? And also it'd be good to look at that from the mum's and the baby's perspective. Thank you so much.
Now, Rebecca didn't tell us what week she was at,
Sure.
so we don't know how pregnant she is.
Sure.
Yep.
I think we've done an episode on ECV, haven't we?
And Breech.
Yeah. So
I think within the Breech episode. Yeah.
I think let's assume for a moment people have had a bit of a listen to the ECV episode and can familiarise themselves with what it involves. Basically, it's a technique whereby we can come into the hospital with a baby in the breech position and under a bit of a controlled environment, place our hands on the pregnant woman's belly and try and turn the baby around. And look, it's an established and well described technique. I've always found it to be a real knack thing, and the people who were the best at it, without question, were the really old guys who trained me when I was at the Royal Women's. Guys that doubtless by now have moved on because they
mean like moved on past otherworldly,
celestially, because they, I think there was a certain era in the medical world where Caesars were dangerous. They hadn't nailed the spinal anaesthetic. They hadn't nailed, and before that, they hadn't nailed the surgical technique.
No, it used to be like up and down the belly, didn't it?
So they had more incentive to avoid caesarean section. And Breech.
Can I tell a quick story about that?
Yeah.
So I grew up in a little country town and had a very Catholic upbringing where our main community was going to church on Sundays.
Sure.
And the people that always filled the front pews were a family that had lots of babies and had lots of babies in succession. And she would have her babies by caesarean by the time, I don't know, the third came or something. And I remember that it was a constant that we were always praying for Mrs. Hill and her caesareans.
I'm sure by then they had achieved significant safety.
Yeah,
but isn't that funny? Like maybe in your mother's mind, that was still a potentially big issue and a dangerous thing.
Yeah,
worth getting your prayers out.
Yep.
That's a cracker. So I think that where does ECV stand in modern obstetric practice in Australia? Certainly, it's done. I don't do it, not because I disapprove of it or don't think it works, but because I don't think I'm good at it.
Yeah.
And I haven't, and I don't do nearly enough. But I've got some colleagues in Melbourne who do, and occasionally I'll send people to them. Only because I think that if you're going to do ECVs, you probably should do a fair few and be good at it. Yeah. There was, the caller said about for mother and baby, it's hard to know what a baby's experiencing on the inside, but there are some fetal risks involved in doing it, which is why it should be done in a hospital where under fetal heart rate monitoring, so that if a significant problem occurs, you can proceed immediately to caesarean section. And then for the mothers, it's a little it's unpleasant.
Yeah.
To get the baby to turn around and sort of do a forward roll, you need to disengage the breech from the pelvis. So the baby's bum is the breech. That's right down in the pelvis in late pregnancy, and you've got to push that up out of the pelvis and then flip the baby around, and it hurts. I
would say that would feel quite painful.
Yeah.
Are they lying on their back when this happens?
Yeah. So so it's not that pleasant. The other thing I think where ECV kind of sits is that once upon a time, people, an individual woman had more babies than they do now, and I think that if you were thinking you might have had 4 or 5 babies, and you were trying to avoid 4 or 5 sections, then an ECV might have been worth it if your first baby was in a breech presentation, because then you could get that baby to flip around, have that baby vaginally and all the other babies vaginally. And it's a little different these days, especially in my private practice where people want 2 and they get started later. And this is not from me, this is from my patients, that they are less worried about having those babies by caesarean section if that's what needs to happen. I think that ECV is probably limited by patient demand. I don't have a lot of people saying, should we do this? For my patients, more often than I recommend ECV, if they want my recommendation, we often spend a lot of time talking to people about risks and benefits, but the choice is up to you. But then sometimes people turn around and say, yeah, I understand that, but what do you think I should do?
What would you do? If it was your wife, what would you do?
More often than I recommend ECV, I recommend a section for the breech baby and a VBAC for the second baby. And that way you get what I think is the safest option without, but also still experience a vaginal birth with the VBAC. And typically a woman having her second baby, if she had the first Caesar for breech and the second baby is cephalic and she has that baby by VBAC, then she would be considered a good VBAC candidate because for all we know, she labours terrific. It's just we didn't do it because we did a Caesar. Yeah.
And, it just so happens, gosh, things are in cycles, but all of our, well, not all, but so many of our questions in the latest batch of speak pipes were about VBAC. So you say about people not having as many babies, but the cycle comes and goes where the what's in their heart, what's in people's heart is to have a vaginal birth.
Yes.
And so this cycle is that people really do want to experience a vaginal birth, maybe feel disappointed or feel like they didn't have that experience that they thought childbirth was in their first and are looking for answers about VBAC. It's interesting because just not that long ago, everyone was asking for a planned cesarean. So, I don't know what happens.
Topics come and go in the public's attention. That's true. But I think that some trends have emerged over the years. And I think one is that supporting VBAC, encouraging VBAC and putting and conducting VBACs when it might have been easier to do a Caesar, all of that is really important in maintaining choice. And I think that it really helps if I'm recommending for solid obstetric reasons that a woman has her first baby by cesarean section. I think it really helps to know that I mean it when I say that you're likely to be a good candidate for VBAC next time around. And that person can say, fine, I'll have this baby by cesarean section because it's the wisest decision for today. But next time, if it's in my heart to have a VBAC, I will.
Yeah. And maybe the questions that patients should be asking is, have you done ECVs? What are the success rates? Like, what's your experience for that particular practitioner? Like we could give you lots of things about ECVs, but, if you've got a practitioner that's done many, and I don't even know, what would you count as many ECVs? What would give you enough experience to go, yep, I can put my hand on my heart and say, yep.
Dozens of previous and several a year.
Yeah.
And that's not me when it comes to ECV.
Yeah.
So I would only want to, if this was me or you, I would only want to.
It'd be weird if it was you.
I would only want to do that if I knew that I would only want to take the inherent risks if there was a promise of success.
Yeah.
A reasonable likelihood of success.
Yeah.
Otherwise, it's all risk and no benefit.
Yeah.
So I'd be saying I would want to be where the success rate was known and acceptable to me.
Yeah.
That would be a real part of assessing the risk for me.
Yeah. And the other question I perhaps would be asking my practitioner is, how many VBACs have you attended? How many VBACs have been successful for you? Yeah. Is it something that you have patience for time? Because sometimes it takes a bit longer, doesn't it?
And would you consider me on the basis of what's happened so far? If I have this Caesar now, would you consider me a good VBAC candidate in 2.5 years' time?
Yeah. And if for all the other VBAC questions that we had in the list today, we've got a really great story. One of our patients helped us out on the VBAC episode where she told her story. Yeah. Yeah. And it's really lovely to listen to. Good. All righty. We're going to move on now, Pat.
Hi, Dr. Pat and Brigid. I have a 2-part question. I recently gave birth to my first daughter, full-term uncomplicated pregnancy other than hyperemesis. She was induced 24 hours after spontaneous rupture of membranes without progression. I ended up having a beautiful water birth with 4-hour and 20-minute labour, 17-minute pushing phase. I experienced the fetal ejection reflex and did not need to actively push except for her shoulders. My daughter then had a full resus and a bag of blood due to a hemorrhage caused by a shearing injury to the cord, which impacted 2 of the 3 blood vessels. This was not apparent until after the shoulders were delivered and the blood escaped. She is now a perfectly healthy and happy 4-month-old. My first question is, how likely am I to experience the fetal ejection reflex for subsequent births? Secondly, what is your experience with shearing injuries to the cord? We're waiting on state histopathology results, and there is limited research on the actual causes of shearing injuries from what I can find. Thank you.
Did you hear a little baby squeak?
Was there?
Yeah.
I didn't hear that. That's nice.
I love she's quite an optimistic person, because other people would describe the pregnancy and birth kind of differently.
Yes,
with
if
the
there was
pessimistic
if the
slant.
newborn needed a blood transfusion, yeah.
Also, that she had a pregnancy with hyperemesis. Ugh.
Yeah.
You know, like
Yeah.
that in itself can be traumatic for people.
So that's good. That's a really glass half full way of looking at it. So that was a pregnancy that did have its issues, but a cracking labour. Terrific. So the piece of that I want to discuss today is this injury to the cord. Those are not at all common. And remember, the blood that's in the cord, that's the baby's blood, and we don't want to let it leak out. So it is possible to get some sort of shearing forces on the cord, and the cord can break and fetal blood leaks out, and then the baby can be left anemic. And that seems to be what happened on this occasion, and then the baby needed a transfusion. And often it would be obvious that that's what's happened. There's a bit of debate about exactly why it happens. I think some of them would be due to difficult birth, traumatic parts of the birth. If the cord was up next to the fetal head and forceps were used, for example, then it could damage the cord.
The speed of this birth?
I don't think that's likely to be relevant, because fast births happen all the time, and cord shearing injuries are really uncommon.
Hang on. What is shearing? What does that mean? That it's sheared off?
Yeah, like it's just been sort of, force has been applied to it, and it's broken.
Wow.
Yeah. So I guess that it could be explained by some intervention in the birth, like forceps on rare occasions, but also there are some cords that are very thin and fragile, and that's typically related to prematurity. Although sometimes a term baby has a really thin and fragile cord, and you go to put a little bit of traction on the cord to help the placenta come out, and it breaks. Whereas we like a cord to be a pretty fat sort of thing, with lots of this cord protection around it called Wharton's jelly, where the cord is good centimetre across and it's fat, and the vessels inside it are protected by all this jelly and less likely to be squished by the head. Yeah. So a really uncommon scenario, but one in this case that was obviously picked up. Obviously, the cord was noted to be damaged. There was fetal blood coming out of it, and they dealt with that, and the paediatricians arranged a transfusion for the baby.
Is there any correlation between a pregnancy with hyperemesis and the quality of the cord?
No, not that I'm aware of. I don't think that's a connection that's ever been made. I think that cords, some are fat and some are thin, and I don't know if anyone really knows the reasons behind that. So I think our callers should be confident that this is a super rare thing, that by virtue of being super rare is unlikely to happen again.
Yeah.
Yeah. There may be a tiny subgroup. This might have been the research she was looking for, about whether there's someone who sort of inherently makes cords that are prone to damage. I don't believe that's an established phenomenon, but someone may be looking into that. But I would have thought that that the phenomenon was so rare that she could confidently have another vaginal birth, and that could be an outcome that could be closely watched for, but is most unlikely to happen again.
That's the problem, in a lot of pregnancy research, isn't it? Sometimes these super rare things, it's hard to get good, robust information research around it because, how do you even set up a research
it's not happening
program
commonly enough. Yeah, that's right.
She talks a little bit, just want to touch on the fetal ejection reflex.
Oh, yes.
What is it?
Oh,
does everyone get it?
Yeah, I think that what most people are talking about when they talk about a fetal ejection reflex is getting to that state where the body pretty much automatically ejects the baby. And whether that's the same thing as pushing but happens automatically, or whether it's like pushing that just happens without you thinking you're pushing.
Yeah.
Or whether it's a totally different phenomenon, I don't know. I don't know which of those is true. But certainly it's very, very useful to get to the point where you can't help but push. Yeah. And whether you're actually pushing because you can't resist it, like doing half a poo, it's hard to stop halfway through and just say, well, I'm done now. Your body wants to keep going. Right? That's where you want to get to.
Yeah.
And if women in labour are pushing automatically, deliberately, I don't think it matters, but it's happening whether they feel like they can control it or not.
Yeah.
That's really a great place to get to. Lots of the pushing that's done before then, where you're choosing to push, it's useful, but it's you can wear yourself out.
Yeah.
And if you start choosing to push too early because you've been recommended, better start pushing, and people have got 1 or 2 hours of that in them, and then if baby's still not out, we can be setting ourselves up for a higher chance of an instrumental birth. Whereas all things being equal, and if there's no rush, and there's no concerns about fetal well-being, and we wait for fetal head to descend further down into the pelvis, then we can reach a point where you can't help but push, and that's way more efficient and likely to be able to get the baby out before you're exhausted.
Yeah. Anyone listening to this and then all of a sudden going, oh my God, now I've got to think about pushing. Guess what? We have an episode on that. So we'll put that in the show notes as well. And, I like how you describe it because sometimes she actually described it as she didn't have to push until she got to the shoulders.
Yes.
So, but she has been pushing probably beforehand. But
that's right. And she asked about whether the happened again.
Yeah.
I think that phenomenon is more common the more babies you have.
Yeah.
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 So you dilate quickly, the head descends quickly. There's less resistance to the tissue around the birth canal, and the fetal head arrives near the vaginal opening faster, and then there's an overwhelming urge to expel.
Yeah.
Yeah.
Great. All right. Good luck with your research. If you find anything, just maybe you could send it to us and we'll assess it and maybe even do an episode on it if it's something that is a valid research paper to be talking about.
Quick question. Are you tired of the news? Do you want a podcast that isn't self-improvement? Come get unleashed. It's funny.
I also think that underwear is sort of almost like a new marriage. Like it starts off, it gives you the best of what it offers at the beginning.
It's unhinged.
I have a bit of a thing for my friend's husband's salami.
Oh, hello.
It's not here to teach you anything.
I need to make sure he looks at me. One side, I'm going to make a sign. This is what I married because I didn't meet you in time.
Yeah, right.
The other side, with pointing to my son who's 12. Look what we could have had, Lewis.
Yeah, I love it.
It's a good time for Gen X. So search Unleashed wherever you get your podcasts. New episodes every Tuesday.
Alrighty. We've got a repeat caller now, Pat.
Great.
Hi, Dr. Pat and Brigid. I called in December of 2024 after I found out that my son had CMV at 24 weeks and we elected to terminate the pregnancy. I'm calling back to say that we did do IVF again and I had a great 7-week scan yesterday that shows another healthy baby growing. So I wanted to give you that positive update. I wanted to ask a question. My first son, I had a scheduled C-section because of a complete previa, and I was very happy with that experience. With my loss and, delivery of a fetal loss at 26 weeks, I did have a vaginal delivery and had a lot of pain, and wanted to thank you for your thoughtful response to my question. I am planning another repeat C-section and was thinking about doing the risk-reducing salpingectomy because I know this is my last pregnancy, and just wanted your thoughts on how that adds time to the procedure and any potential for delay in initiation of breastfeeding just with adding on that additional procedure. And if you're doing in your practice, what are your thoughts on women choosing to do this procedure? I'm hearing that it can be a good thing to do when you know that you're done with children and having another gynecologic procedure. Anyway, thank you so much for all the work that you do. And again, for your thoughtful responses to all the questions you get. Keep doing the good work. Thanks.
There's so much in that question.
What a great
Yeah.
call.
Yeah.
And how exciting to be pregnant again after all that heartbreak from last time.
And how brave to come back and tell us, thank you. We appreciate that.
Yeah, we appreciate your, your honesty and your openness about that tragic medical scenario you went through last time and the doubtless extremely difficult decision, followed by some happiness that you're due. So well done. The opportunistic salpingectomy is a hot topic at the moment. So.
This will be brand new to many, 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 many people. So we better dive in.
So let's talk about it. Ovarian cancer is still a highly problematic disease. It's reasonably uncommon, but the outcomes for people who get that disease in their 50s, 60s, 70s are still quite poor. And the reason is that the disease is often advanced at the time of diagnosis. And despite surgery, chemotherapy and so forth, 5 years survival rates for ovarian cancer fully treated are still very poor compared to the developments that have been made over the last 20 or 30 years with other cancers, including breast, colorectal, and so forth. So the focus on ovarian cancer is on prevention rather than treatment, because we're a little bit stuck for advances in treatment. Lots of very, very clever people are trying. A different group of very, very clever people are trying to work out a screening test. That's proven difficult. But there's an established intervention that can be done for prevention. And to help with prevention, and that's to have your tubes removed when you finished your family. So, if you have, it turns out that quite a large number of cases of ovarian cancer start in the tubes, and that if you have your tubes removed once you've finished your family, you significantly reduce your overall risk of ever getting ovarian cancer in the first place. Now, your risk would be reduced even further if you had your ovaries removed, but that in most premenopausal women causes more harm than good. Wind up instantly menopausal, needing to take menopausal hormone therapy until you're at least 51 or so, if not longer, and that's not considered standard practice. But your tubes you can live without. They only have a reproductive purpose. They're not otherwise hormonally active, and they can you can easily live without them. So rather than just clip the tubes for contraceptive purposes, we're more likely these days to take them out altogether in someone who comes along and says, I've had enough babies and I want permanent surgical contraception. And then there's a different group who might not even need the contraception. Maybe their husband's had a vasectomy, or maybe they've got an IUD or whatever, but they just want the tubes removed for the ovarian cancer risk reduction. And recently in Australia, one of my colleagues in gynecological oncology has really been very active politically in trying to get other surgical groups to talk to women about the value of having their tubes removed when they have other surgery such as a gallbladder or a appendix or something, because while we're there, we'll take the tubes off. And there are some practical problems with getting that done. We need people to do it properly. It's not quite as easy as it looks, but it's not a big surgical intervention. And if you're having another operation for a different reason, and the surgeon had capability of taking your tubes off, or they had a capability of bringing in a gynecologist to quickly do it, then great. So one of the most obvious times to do a contraceptive procedure has been at the last birth, if that birth is by cesarean section, because you've got the tummy open and the tubes are sitting right there. And it's quite technically straightforward in most cases to remove the tubes pretty quickly. They can bleed, but we've got ways around that, a technique that prevents most bleeding. And rather than just putting 2 quick clips on the tubes, we'll just take them off altogether. And then that woman gets the benefit of permanent contraception and ovarian cancer risk reduction. It doesn't add it adds an extra 10 or 15 minutes to the Caesar, but that's not a problem. It can still be done under the same single-shot spinal anaesthetic, and it doesn't add a particularly problematic increase in time. That's not going to translate to post-operative problems, interrupt the bonding process, change breastfeeding results, anything like that.
So if this is being offered to this woman, you'd say, if that's what you want to do, go for it.
Yeah. In skilled, experienced hands, it might add 10 minutes to your Caesar.
I just want to test because so here in Ballarat we've got a St John of God, so a religious-based hospital.
Yes, Catholic Church-owned hospital.
Yeah,
who haven't previously been that keen to have contraceptive procedures done in their hospital, but are happy for the tubes to be removed if the primary purpose is ovarian cancer risk reduction.
Well, Pat, I think that's all we've got time for today.
Well, they were good.
They were all good.
Yeah.
They're always good.
Always good.
Yeah. We love our audience. You guys are very clever people, and you're clever because you're asking. You're asking the right questions. And you're seeking the answers. We hope that we're always here to give you those answers that you're looking for. You can just tell us. If not, just get into our DMs and say, hey, the way that you answered blah blah, that was wrong. That was wrong. I've had it on very good authority, aka ChatGPT. and we'll record and we'll talk about it. Yeah, good. All right. Until next week, everybody, we hope that you're having a very lovely week. And if you're aiming to get pregnant, that happens for you this week. Wouldn't that be great? There we go. Bit of baby dust. Until then, keep growing your babies, and we'll be in your ears next week.
Thanks for listening, everybody.
Okay. Bye for now. Hey, even though Dr. Pat is, a doctor, and we get lots of other doctors and other experts on our podcast, I just need to remind you that this podcast is for informational purposes only. We share lots of medical insights and experience, but everything we talk about is general in nature and may not apply to your specific situation. Please always consult with your own healthcare provider for your individual medical advice when you grow your baby.